Last time we wrapped up and compared small bowel obstructions versus large bowel obstructions. We looked at all the things that were related to, before that, we looked at all the things related to gastric bypass surgeries and whether it's a small intestinal bacterial overgrowth or dumping syndrome and all the other things. Now, there were a couple things that needed to be compared. So let me actually point that out to make sure that you guys spend ample time making sure you know the differences. The first one was, and this is all stuff in step one as well, but in step one it wasn't really tested in this manner per se. They had these topics in step one as well though. So you have your small bowel obstruction versus ileus. All right, that's one topic you want to make sure you can differentiate: small bowel obstruction versus ileus. So these two tables do the general job of that, and then the practice questions show you more of that stuff. But generally speaking, small bowel obstruction, it will be related to someone who had a surgery not too long ago, right? Pretty recent surgery, up to a year ago. And the ileus people, those are people who just had surgery, right? So that's one huge thing that you'll see in questions, like in the clinical scenario, right? And what's the real issue that helps you differentiate? Well, with small bowel obstruction, you're going to have the increased bowel sounds, and there's going to be large bowel dilation that's not there. Right? So large bowel is going to be perfectly fine. No dilation of the large bowel. It will be seen. And you can see that in these x-rays. So if you look at the top and the bottom, the top x-ray is for ileus, where you have dilation of the large bowel. So you see pretty much everything here is dilated, right? There's big bubbles throughout. Everything here is dilated from top to bottom to all around. Whereas in the small bowel obstruction, you know different things on x-ray. And again, they love giving you the x-ray, especially on CK, but in step one, they were more prone to actually just mentioning these things verbally, right? So you would see these air fluid levels in the small intestine in the small bowel obstruction patients. But the large bowel, remember the tract that your large bowel takes, right? So you have your ascending colon, transverse, and descending colon, right? The large bowel is mainly all going to be just fine. Now, the large bowel is going like this, but you don't see it because nothing's happening in it. What you're seeing is the darker thing behind it, which is all of this, right? All of this, because there's a problem there. There's an obstruction that's causing things to build up. And again, you're going to get presentations of patients having the symptoms of when things build up, like vomiting, right? Because if it doesn't go all the way, it's going to come back up. So both of these tables together do the job to help you really see the difference, okay? So again, prior surgery, weeks to years ago, there's going to be increased bowel sounds, and there's going to be no dilation of the large bowel. Okay, no dilation of the large bowel and small bowel obstruction. These patients usually have obstipation, which means that there's no anything coming out of the butt. No farting, no gas or feces, either one of those, right? So that's what obstipation is. Constipation usually means that you're unable to poop, but there's still gas that's passing. and one, of course, that you always want to make sure you have that in mind, okay? Because that's a giveaway in comparison to ileus, where there is just no flatus. Right? That's the difference. They don't have obstipation in ileus. So continuing on, small bowel obstruction, there's going to be obstipation, which is easy to remember because obstruction, obstipation, right? And of course, if you know what it means, right? If there's an obstruction, nothing's going to go past that point, so nothing's going to come out of the butt. That's it. And then on x-rays, you have the air fluid levels we just looked at, little to no air in the colon or rectum, which is why we don't really see the rectum, right? I mean the colon. We can't see it. We can't really visualize the colon on this x-ray at all, right? But here you can visualize everything. Everything is visible. There's not a single part that we don't see anything. It's not blank anywhere, right? In the ileus. So in ileus, they have recent surgery that is now going to lead to ileus from occurring, like paralytic ileus. And there will be metabolic derangements like hypokalemia. It could also be medication induced. You can see it with painkillers as well. Patients can get ileus. Their key feature is that everything is dilated. Small bowel is dilated and large bowel is dilated. So everything is going to be tympanic. You can feel air and hear air throughout their entire abdomen. Their presenting feature that's really interesting is the complete absence of bowel sounds. right? No bowel sounds at all. Right here, you could have hyperactive bowel sounds or absent bowel sounds. It really depends on where the obstruction occurred. But in these people, there will be no bowel sounds for sure, and there will be no flatus. Right? They're not going to be passing air per se, but they will have nausea and vomiting and the possibility of constipation. On X-ray, as we saw here, everything is dilated. Right? So there's air in the colon and the rectum, as well as the small intestine and everything. So that's your small bowel obstruction versus ileus comparison. You want to make sure you can differentiate the two, and you're going to see practice questions, especially when you do your own practice questions in UWorld and NAMBOSS, that there's going to be a lot of differentiating happening between the two case scenarios. Then you move on into here, and there's going to be comparisons of small bowel obstruction versus large bowel obstruction, right? Comparing those two. And they have an entire table for that too. So here what I did was I kind of highlighted for you guys the key things that you're going to need to know. So here on the top right is another x-ray showing you once again small bowel obstruction, complicated small bowel obstruction. There's perforation that must have occurred, and you can see the air fluid levels, and the flat lines are a giveaway for air fluid levels. So that's what you're going to be counting on to pick small bowel obstruction. You don't really get that in large bowel obstruction, air fluid levels. You don't have that. Right, so small bowel obstruction versus large bowel obstruction, the things I highlighted are the key things that are different between the two. So as we already saw, small bowel obstruction is moderate to severe acute abdominal pain with copious vomiting, called copious emesis, cramping pain with the distal small bowel obstruction, fever, signs of dehydration, and hypotension may be seen. There's going to be abdominal distension in the distal SBO, abdominal tenderness, visible peristaltic waves. Right? Peristalsis is working. Otherwise, if there was no peristalsis, then it would be considered ileus. Fever, hypovolemia, look for surgical scars. As we said, there might have been a surgery these people have had like weeks to years ago. Perform a rectal exam, and then they have this description of a high-pitched, tinkly bowel sound. Later, there will be absence of bowel sounds. Right? So this, again, I didn't highlight that because this is seen in both obstructions. They both have that, so it's not exactly something that differentiates the two. Etiology of a SBO, adhesions post-surgery, which is why you look for surgical scars. It could be due to hernias, neoplasms that are obstructing flow, volvulus, interception. Of course, volvulus and interception both are twisting of intestines in such a way that nothing can pass through that now because you tied the knot too tight. Gallstone ileus we saw is when a gallstone comes through the gallbladder into the small intestine and gets stuck at the ileocecal valve. So that's a whole different scenario of its own. Foreign body, Crohn's disease, cystic fibrosis, strictures, and hematoma. There's a bunch of things that can cause small bowel obstruction, and it's a very high yield topic. Differentials are going to be the large bowel obstruction, which is what we're looking at right now, paralytic ileus, and gastroenteritis. When you do the labs, they both pretty much have the same stuff: CBC, electrolytes, lactic acid, x-ray of the abdomen, and you're going to see everything you're going to see, and we're going to be looking at some figures for that. So that's, let me see, 2.6. That's 7. Where did they show that? Did we already look at it? I think that was it up above, right? Yeah. 2.6, that's 8, is acute diverticulitis, large bowel. This is a large bowel obstruction for 2.6-9. Where was the 2.6-6? Oh, this stuff right here. Okay, so we already looked at it. This 7, I mean. Yeah, small bowel obstruction. So again, in small bowel obstruction, every time you will always notice the same thing, the issue being that things are in the small intestine that are causing the problem. You can visualize the small intestine pretty well, right? And they're pointing it out here too. What you can't see is the large intestine, right? You can't see the colon. Cannot see the colon. Same thing in here as well, right? There's a lot of dilations happening here in this area and in this area, which is very high up. There's some dilation on this side here, right? And in here, which is dead smack in the center. That's your small intestine. But the large intestine is okay for the most part. Right, so X-ray abdomen shows dilated air-filled small bowel loops with relatively little gas in the actual colon. The colon doesn't have much gas in it. Right, so those X-rays are actually really good for exactly what you're going to be looking for. In the large bowel obstruction one here, they talked about the bird's beak upside down. Right, so this is the same bird's beak that you would have in achalasia. When achalasia was in the esophagus, here it's on the other side. Right. But yeah, generally speaking, they're both going to have the same exact stuff, just the x-rays are going to be different. The x-ray is actually the key difference between the two. for diagnosis purposes. And then, of course, you could do contrast studies where here you would order a CT scan to see air fluid levels other than what you saw in X-ray already. But in the large bowel obstruction, you would need a sigmoidoscopy or colonoscopy to come through into the large bowel from the other side and see what's happening. But you don't order these things if the patient isn't stable, right? If they're bleeding, if they're becoming more anemic or hypotensive, you can worsen things. Treatment for both is generally going to be first to hospitalize because they can be treated at home. This is not going to get better by itself. For the SBO, partial SBO can be treated conservatively with nasogastric decompression and NPO status. Right? Don't keep eating. Patients with complete SBO should be managed aggressively with NPO status, nasogastric decompression, IV fluids, electrolyte replacement, and surgical correction. This is usually essential in patients who have complete SBO. With large bowel obstruction can be relieved with some gastrografin enema. Right, so there's a lot of enemas that you can take. The enemas are, I've never really had to use one myself. I've had to tell patients to use an enema in preparation of colonoscopies and other procedures of sorts. But yeah, enemas are very helpful. And there are enemas that people can even use at home pretty effectively. So that's something that some patients often tend to try if they're up for it. But yeah, colonoscopy or a rectal tube. However, surgery is usually required. Once again, a surgical correction. An ischemic colon usually requires partial colectomy to get rid of whatever part is dead now, because the ischemia usually leads to a dead portion of the colon. And then we talked about colorectal cancer. We went into the differences of all those things there, and now we're up to GI tract bleeding and inflammatory bowel disease, where we're generally going to be jumping right into Crohn versus ulcerative colitis. So let's keep that open right there. So GI bleeding presents as hematemesis, metachesia, and romelina. Upper GI tract bleeding from lesions proximal to the ligament of Treitz, the anatomic boundary between the duodenum and jejunum. Table 2.6-H presents the features of upper and lower GI bleeding. Right? So right here you have all the different types of GI bleeding that can occur. And GI bleeding is huge, and patients will immediately come into the clinic as soon as they see the blood. They start panicking. Right? So with upper GI bleeding, you're going to have coffee ground emesis. You're going to vomit stuff that, when mixed with the contents of your stomach, end up looking like coffee ground. It's the dried up blood that's giving it the coffee color. Melena, more common than hematochezia. Hypovolemia, because of course you're losing blood. Elevated blood urea nitrogen, because of all the hemoglobin that's being broken down. Tachycardia, lightheadedness, and hypotension because you lost blood. Right? Nasogastric tube and lavage may be negative in 15% of upper GI bleeds. Endoscopy is definitive. You have to go in and see where the bleeding is coming from. Etiologies could be a peptic ulcer disease, esophagitis, gastritis, a Mallory-Weiss tear, esophageal gastric varices, gastric antrovascular ectasia, and dilophoid lesions. Now, these last two things, the gastric antrovascular ectasia and the dilophoid lesions, especially the dilophoid lesions, are probably things you've never really heard of. The book doesn't really talk about it anymore, and I have yet to really see a UWorld question where either one of those things were actually tested. But when you're done with the topic, when you feel confident that you got the rest of this down pretty well, then you can come back and look at this again. So highlight it or something for yourself. Don't spend time or waste any effort on it right now, because you don't want to start looking at new things until you've gotten everything else down pretty well. Or maybe you do, then you can do it if there's no stopping you on that. But definitely make sure at some point, either now or after you master everything, you take a look at these guys, because they're not really mentioned anywhere. I haven't seen them anywhere. I can't really say you won't get tested on it though, since it's here, so know it. Initial management: protect the airway, of course, right? If they're bleeding and they have hematemesis, you gotta protect the airway. You don't want them to choke on it or take it into their lungs. That's gonna worsen things into aspiration pneumonia, and you definitely don't want that to happen. Protect the airway. This protect the airway thing is something that all nurses are practically taught like a religion. Right? They have to know this. They have to do this. And then, of course, stabilize the patient with IV fluids and packed red blood cells, because they're losing blood, so you give it to them. Right? But this is initial management. So again, this is what you get questions on. What's the next best step? This is what they're talking about. Because if you have a person with upper GI bleed, you can't do anything about any of these etiologies immediately. Right? You can't. In fact, you won't even know what the etiology is until you go in and look with an endoscopy. So before you go in to look at what's happening and find the etiology, right, before you do this endoscopy and find the etiology, you have to take care of the patient and make sure they don't die while they're suffering, right? So you protect the airway and stabilize them with IV fluids and red blood cells. Then, once they're stable, you can do an endoscopy, see what's happening, see where the bleeding is coming from, find out the etiology, and then deal with that etiology, right? So step 1 students know that when you get an upper GI bleeding kind of thing, you immediately find the etiology, and that's all the question is ever about. But when you read those step 1 questions, let's say you're looking at a step 1 question about peptic ulcer disease, it'll start off with the patient came in, has X, Y, and Z symptoms, they're vomiting blood. The question will go on to tell you in the question that they intubated the patient and then gave the patient IV fluids and packed red blood cells. And then they'll tell you labs, they'll tell you the patient's blood pressure and stuff, it'll show you that they're stable, they'll say that they did an endoscopy, they found out whatever the etiology is, and then they'll ask you what to do about the etiology. Right? So that was kind of what step 1 was doing. So in doing so, in writing such a question, the step 1 exam was actually teaching you how to manage it too. Right? And that's what you want to be careful with. You don't want to fall into the step 1 trap where you just immediately pick that the next best step here will be to just do an endoscopy or to just go ahead and deal with whatever the etiology you think it might be. Right? If the question is not mentioning that the patient is stabilized, you don't do an endoscopy right now. Stabilize the patient. That has to be the answer choice. If the answer choice is not there, then you move on to whatever else is there. Right? For the lower GI bleeding, this is where you usually think that the patient might have colorectal cancer and they're going to present with anemia. So there's going to be hematochezia more often than melena, but can be either. Right? So this is true for only here. This is backwards for both of them. So upper GI bleeding usually has melena. Lower GI bleeding has hematochezia. Right? So that's another little silly thing you can get stupid questions on, or a little silly detail that can be in the question to help you differentiate between upper versus lower GI bleeding. So lower GI bleeding, you got to rule out upper GI hemorrhage with a nasogastric lavage if brisk. Anoscopy or sigmoidoscopy for patients under 45 years of age with small volume bleeding. Colonoscopy if stable. Arteriography or exploratory laparotomy if unstable. Right? So you have to do different things depending on how their vitals are looking like. Usually in lower GI bleeding, it's going to be because of diverticulosis, right? Those pouches that were forming that we already looked at. Other case scenarios could include angiodysplasia, IBD, which we're going to look at today, hemorrhoids or fissures, which are really not going to be a per se lower GI bleed, but they're more external. They're by the rectum already. It's not coming from the colon. Neoplasm or AV malformations, right? AV malformations. Initial management, again, stabilize the patient with IV fluids and red blood cells, and then you move on to do whatever you can to diagnose them, and then deal with the etiology once you find it. And so remember the order: number 1, number 2, and then deal with it once you find the etiology. Right. So the first step in management is never just to diagnose or treat. Gotta stabilize the patient first. Yeah, then it moves on to the ulcerative versus Crohn. Okay, so these questions, let me just make sure I know what they're about. Abdominal X-ray. This is IBD also, and this one is angiodysplasia. Okay, so this question is related to what we were looking at right now, so let's take a look at it. 65-year-old woman comes to the office due to GI bleed. She has had 3 or 4 episodes of dark maroon colored stools in the last 2 weeks with normal intervening bowel movements. Alright, so dark colored stools, right? So that's one thing. The patient has no associated abdominal or rectal pain, nausea, or vomiting. She has a history of hypertension, diabetes, and hypercholesterolemia. Okay. Temperature is fine, blood pressure is high, pulse is 95, respiratory is 16. Physical exam reveals a 3 out of 6 systolic ejection murmur in the right second intercostal space. So now you gotta know what that is. Carotid pulses are delayed on palpation bilaterally. Abdominal and rectal exam are benign. Lab results are as follows. Hemoglobin is a little low. And so it's microcytic anemia. MCV is 90. BUN is 34, which means that there's hemoglobin that's being bled out. All right. And creatinine is 1.6. So renal function is also being impaired now. This is a pretty elderly patient, right? Elderly female patient. Colonoscopy 6 months ago was fine, but was somewhat limited in the ascending colon, due to suboptimal bowel preparation. So she couldn't get everything out. So remember, before doing a colonoscopy, the night before, you're supposed to take laxatives and just get everything out. There's going to be good osmotic laxatives that the doctor will prescribe, or an enema to really just help get everything out so that the colon is empty and everything can be visualized. What is the most likely cause of her symptoms? Okay, so not exactly a lot is given in this question. But when you look at your answer choices, you should be able to figure it out. However, people were pretty confused. 50% of people chose the correct answer, angiodysplasia. Great. But then everyone else was pretty spread out. 15% each chose colon cancer, diverticulosis, or ischemic colitis. Right? But you have to know the key features that differentiate each one of those things. This clinical presentation of episodic painless GI bleeding, the key feature being painless, suggests angiodysplasia, which is characterized by dilated submucosal veins and AV malformations, and has an increased incidence after age 60. It may occur anywhere in the GIT, but is most common in the right colon, the ascending one, the one that they couldn't really have seen. Right? They couldn't see it in the previous colonoscopy, so they were really giving it away that whatever is wrong has occurred in the ascending colon. All right? And we talked about the differences last time. Right, where ascending colon and descending colon had different kinds of issues. It was the descending colon where you had the apple core lesion occurring. So let's make sure we have that solidified. You always want to make sure, if you can't tell it to yourself without looking at the book, you go back and look at it. Right, always go back and look at it. So let me see right here. Right-sided lesions, which is your ascending colon, often has bulky ulcerating masses that lead to anemia from chronic occult blood loss. Our patient is having blood loss as well. Patients may complain of weight loss, anorexia, diarrhea, weakness, or vague abdominal pain, but our patient doesn't have pain, which actually ruled out a lot of those answer choices. So in this side, you basically, right colon has a large diameter, so obstruction is rare. Right? It's just ulceration, ulcerating masses that occur on the right side. Right? Left side typically has the apple core obstruction. Left side has a smaller diameter, so it's easy to obstruct. Right, so you get an obstructing mass that will easily be seen as soon as you do a colonoscopy. All right. So that being said, common in the right colon, angiodysplasia is more frequently diagnosed in patients with advanced renal disease and von Willebrand disease, possibly due to the bleeding tendency associated with these disorders. Angiodysplasia may also be more common in patients with aortic stenosis, possibly due to acquired von Willebrand factor deficiency, from disruption of the von Willebrand multiples as they pass the turbulent valve space induced by aortic stenosis, which is what her systolic ejection murmur was. Angiodysplastic bleeding has been reported to remit following aortic valve replacement. So actually, to treat her, you would eventually have to treat, or at some point once she's stabilized and everything's okay, you would have to actually treat the aortic stenosis, and then she'll actually be okay. Right, aortic stenosis is extremely terrible for a patient for multiple reasons. I mean, for the heart itself, it's really bad, and then now you have this. Right, aortic stenosis we already saw was really bad for you because you can't get any blood out of the heart, which means lesser blood going into the brain and lesser blood coming back down to even go into the coronary left and right arteries. Diagnosis is made on endoscopic evaluation. However, it is not uncommon for it to be missed on colonoscopy due to poor bowel preparation or location behind some kind of haustral fold. Asymptomatic patients do not require treatment. Patients with anemia or gross occult bleeding can be treated endoscopically with cautery. Right? So you just cauterize wherever the bleeding is happening, but then you definitely have to come back and make sure you deal with their aortic valve. Right, so that's another reason they chose a 65-year-old patient, because with aging, aortic stenosis is more common. Right, so diagnosing this murmur was the easy part. And then once you saw that, it needed to ring a bell for you. In fact, this topic is talked about in step 1 in pretty good depth. I believe in hematology, but I can't remember where. Let's see if I can find it. So this is kind of why I like using PDFs. It's like very easy to actually find stuff. It is in GIT. Alright, but they talk about it again in I'll hit enter again to see what they say anywhere else. So here in GIT, they mention angiodysplasia, tortuous dilation of vessels leads to hematochezia. Most often found in the right-sided colon, which is the ascending colon. So in our question, they couldn't see the ascending colon. More common in older patients, confirmed with angiography associated with aortic stenosis and von Willebrand disease. Right, so look for a patient with aortic stenosis or von Willebrand disease with anemia and painless rectal bleeding with a normal colonoscopy. That's exactly what happened in our question in CK. right? I put that note here after probably having had seen some step 1 question, right? Aortic stenosis will cause the SAD symptoms and have pulsus parvis et tardus. Von Willebrand patients will have, I didn't finish it up, but they're going to have the bleeding associations with von Willebrand, right? In fact, von Willebrand being autosomal dominant, usually in step it'll occur to men, but it can occur to women too, right? So that's the story of angiodysplasia right here. Let me see. I think they mentioned it one more time somewhere too. Let's see. I believe I don't know. It's ringing a bell for me in neuro or hematology somewhere, but it's not going to come up. All right. So let me see. Maybe I'll find it here. Since this doesn't have too many annotations or anything. What is this? This is new. So upper versus lower GI bleeding is now in First Aid 2021. So they just listed it out. Not that significant of a thing. Basically listing it out. They have angiodysplasia, the same page, in GIT, and then where else is it mentioned? Nowhere else. Okay, so I might be confusing it with something. But either way, this is in here, right? So angiodysplasia is in First Aid Step 1 as well, and it's here. And the presentation in this question was classic. Now, the key thing in this explanation, the most important thing in the explanation was that her bleeding was painless. Right? Now, if you look at the explanation for the other answer choices, colon cancer, it could cause painless bleeding, but cancer capable of causing gross bleeding, as seen in her, is unlikely to have been missed on a colonoscopy. In fact, you wouldn't pick this as an answer choice, colon cancer, because she had a colonoscopy done. And so it wasn't likely to pick this, and would likely lead to really bad microcytic anemia with an MCV far below 80, if she did have it in the ascending part. Diverticulosis is also unlikely to have been missed on colonoscopy. In addition, diverticular bleeding is usually arterial and typically results in passage of bright red blood, not maroon colored. Right? Another key thing to keep in mind, this is stuff that a professional GI doctor would just know like the back of his hand. Right? So all your diverticular bleeding is arterial blood, which is why we talked about it so much, right? I told you guys that diverticula, those outpouchings actually form right where the arteries are going through into the colon. And so bright red blood, maroon colored non-high oxygen blood is usually going to be venous blood. So again, another thing, diverticulosis, right? Very, very key thing to watch out for. Both of these things, diverticulosis and colon cancer, would have probably been seen on the colonoscopy, because diverticulosis doesn't just occur in the ascending colon. It occurs in multiple parts of the colon. You would see it. Last one, ischemic colitis. This presents with sudden onset of abdominal pain. It's a colitis and it's ischemic. Remember, ischemic things just like angina, the heart-related shit. This causes sort of an angina in the abdominal stuff. Right? Ischemic colitis usually presents with sudden onset abdominal pain and tenderness followed by rectal bleeding or bloody diarrhea. But this patient has no pain. Ischemia is painful. Right? So not a bad question at all. All right, this is related to different types of bleeds, and this is the one type of bleed that's very rare in terms of like our experiences as students, but it can definitely show up in your questions. Right? So that's one thing. Now let's dive into our big guys, ulcerative colitis versus Crohn's disease. So let's look at ulcerative colitis first, right? We'll look at it here, and then we'll go to step 1 as well. Ulcerative colitis is better to have than Crohn's disease if you had to pick between one over the other. Now, I did my surgery rotation. Since surgery is a 12-week rotation, it was broken up into, I believe, 3 weeks each. I did 4 different rotations. So one of them was 4 weeks of GI surgery, right? And I met many patients with ulcerative colitis, Crohn's disease. And what was really particularly interesting, I did it in Atlanta, Georgia, but, you know, all the patients I had that had these issues were white. Atlanta, Georgia has a very dominant black population. It has a lot of white people too, of course. It has a lot of everything, actually. I found a lot of my own people there too. But it was interesting to see that all the patients I was getting for these conditions, ulcerative and Crohn, were white patients. I actually never had a single black patient that had either ulcerative colitis or Crohn's disease. But that's just my personal experience, not that this is a official statistics or anything like that. ulcerative colitis, rectum is always involved, right? Rectum is always involved, but it's better to have ulcerative colitis than Crohn's disease, where Crohn's disease affects the entire body terribly. We'll see that. Here, the rectum is always involved, and it may extend proximally in a continuous fashion. Right? So another key thing, continuous. Continuous. No skip lesions. Inflammation and ulceration are limited to the mucosa and submucosa. So it doesn't go through. It doesn't go through the muscular layer into the peritoneum. History and exam, you're going to see bloody diarrhea, lower abdominal cramps, tenesmus, urgency. Exam may reveal orthostatic hypotension because of all the bleeding, tachycardia, abdominal tenderness, right? Frank blood on rectal exam, and extraintestinal manifestations, which are a big problem. Toxic megacolon may be presenting findings. Avoid tubes or scopes in view of the risk of perforation. Right? So you have this one big issue of toxic megacolon. And other extraintestinal manifestations, which we're going to see when we go back to the step 1 book. Extraintestinal manifestations can include aphthous stomatitis, episcleritis or uveitis, arthritis, primary sclerosing cholangitis, erythema nodosum, which are painful nodules throughout the legs and arms and stuff, and pyoderma gangrenosum, which looks terrible. It's also pretty unfortunate. But these extraintestinal manifestations can be dealt with and managed pretty well. It's not that ridiculous. And almost all the patients I had with ulcerative colitis, almost all of them, as far as I remember, had erythema nodosum. Right? They all had it. So what does that look like? Let's come back here to Crohn versus UC. So this picture at the bottom is a perfect image for both things. I never got to see pyoderma gangrenosum in real life, but I did see erythema nodosum. Just literally, it looks like bruises, and it hurts like a bruise. Right? It looks like bruises and it hurts like a bruise. Those are things you see in ulcerative colitis. Right? The pyoderma gangrenosum, though, I'm not sure how that occurs, to be entirely honest, but I didn't see anyone with it either. So yeah, there's that. Diagnosis, of course, you could do a CBC, X-ray of the abdomen, stool cultures, ONP, and stool assay for C. difficile. These things you would be doing really just for differentials, to rule other things out, right? So you're not going to see any oocytes or anything like that. You're not going to see any stool cultures. You're not really going to see any C. difficile in these patients because those are not the issue in ulcerative colitis. Colonoscopy can show diffuse and continuous rectal involvement, friability, edema, and pseudopolyps. Definitive diagnosis will require a biopsy. And for treating it, sulfasalazine, mesalamine, right? Everyone was taking pretty much some mixture of these medications, right? Infliximab for refractory or moderate to severe disease, and then a total proctocolectomy can be curative for long-standing or fulminant colitis, even toxic megacolon. This also decreases the cancer risk. So in my surgery rotation, pretty much every ulcerative colitis patient that I saw at some point got a portion of their colon taken out. And then they were much better off. They would come in for follow-up appointments, but since I was only there for a 3-week rotation, I didn't get to see more of it. But I was able to access the files for the entire 12-week rotation, and I kept up with some of the patients just to make sure they were doing okay, see what their progress was, and learn. Right? I just need to see how their entire progress went after that. Now we look at Crohn's disease. So Crohn, this may involve any portion of the GIT, particularly the ileocecal region, in a discontinuous pattern, and the rectum is often spared. So although the rectum is always involved in ulcerative colitis, it doesn't have to be involved in Crohn. In fact, it might not be involved at all. There's going to be transmural inflammation. So let's see, we got discontinuous and then transmural inflammation. Here it said only mucosa and submucosa. Here it goes through submucosa, mucosa, as well as the muscularis external layer. Sometimes leading to fistulas to other organs because the connection will form. Once the inflammation goes through your entire colonic wall, it's going to connect to another colonic wall or the bladder or whatever else is around. Patients will have abdominal pain, mass, low-grade fever, weight loss, watery diarrhea. An exam may reveal fever, abdominal tenderness, or mass, perianal fissures or tags, fistulas, and once again, extraintestinal manifestations. They're going to have the same extraintestinal manifestations as ulcerative colitis, in addition to having fistulas to the skin, bladder, or between bowel loops. Right? So different parts of your bowel loops can connect to each other because there's burning through that's happening. So fistulas. Same lab workup. Right? You do upper GI series with small bowel follow-through. Colonoscopy may show aphthoid, linear, or stellate ulcers. strictures, non-caseating granulomas, cobblestoning, and skip lesions. There's this concept of creeping fat, which may also be present during laparotomy. We'll see that soon in the Step 1 book. And of course, once again, definitive diagnosis just requires a biopsy. Treatment is also pretty similar. I use the same kinds of things. Surgical resection may be necessary if there's a perforation, stricture, fistula, or abscess, but removing parts of the colon is not really a thing here, right? Because since they have discontinuous pattern, you can't really take out an entire portion, because it's like if you have a long portion of colon and maybe in 3 different parts of it there's Crohn's disease, what do you do now? You can't really cut out just those 3 specific parts and connect everything. Not only is that very hard, but there's no guarantee that connecting it is even a good idea at that point, because then they're going to continue getting Crohn in the new parts that you connected. My doctor at that point has shown me this really interesting thing, that imagine if I take the entire small intestine and long intestine as one linear tube, right? So I'm just going to draw one skinny tube for the entire small intestine and then your large intestine, right? So you have your colon. So I'm just drawing out the entire thing as a linear loop rather than curving it up the way it's supposed to be in your abdomen. Now, small intestine isn't really involved in any of this, right? The small intestine, you're not really going to truly see too much about it. I mean, this is going to be ulcerative colitis is mostly going to affect your colon. Crohn's disease could involve any part of the GIT, so let's keep the small intestine for there. So ulcerative colitis is easy. Ulcerative colitis, let's say this is where the rectum is going to be at the end of everything, right? You have your R. So ulcerative colitis is going to affect this area, and that's it. So to treat it, you can cut it all out. And he taught me that you don't cut right there. You go a little further down and cut it from there. Right? Just in case this is spreading in this direction, you don't want to leave any of it there, such that this new area that you left behind ends up getting colitis. Now, cutting out such a big portion of the colon, right, whatever portion it might be, cutting it out ends up being quite problematic for these patients, because now not much food is going to have time to be digested, right? I mean, everything that gets digested in the small intestine, great, but the large intestine's job is usually to absorb water out and stuff like that, and it's not going to go too well. So they often tend to continue having diarrhea. With Crohn's disease, it's much harder, because in Crohn's disease, you're definitely going to have involvement of the ileocecal area. So, this might be the duodenum, then you have your jejunum, then you have your ileum, right? And then you have your colon. This might be the ascending colon, the transverse colon, the descending colon. So in Crohn's disease, this ileocecal area is definitely involved, and this actually leads to many issues for them, and we'll see some of that in Step 1 book 2. So let's say that this area right here is involved, maybe some of this is involved, right? And then this might be involved, and this might be involved, and multiple areas here might be involved. 3 different distinct areas with like maybe an inch apart from each other. You can't really do too much surgery for them, right? There's no way of fixing this. In fact, if you were trying to maybe make things better for them, and let's say you decide you're going to cut this out right here and then connect it. So then if you did that, if you cut those areas out and connected it, right? Let's say that this is it, and you cut these areas out and you connected the two. You could continue developing more Crohn's disease. It would just develop in those 2 areas. That's just how Crohn's is. Right? Any parts that you cut out and reconnect, you continue developing Crohn right there again. So it was like cutting out portions of the colon were just completely useless stuff. It didn't help them very much at all. And so you don't do much much surgery for Crohn patients, because you can't really do much to help them to begin with. Looking at some of these images here, this one on the left is showing Crohn's disease, where the ileocecal area is involved. Right, so the ileocecal region, thickened wall of the terminal ileum, normal wall of the terminal ileum is here. Right, so this part is thickened, and your ileocecal valve is going to become really hard to open at that point. So that's going to cause other issues. In the middle here, well, this is Crohn's disease from an Amboss image showing you H&E high magnification. The green overlay over here on the top shows infiltrating neutrophils. So there's neutrophils everywhere. It's all the little black dots basically. And the yellow overlay shows a non-caseating granuloma. These features indicate transmural inflammation characteristic of Crohn's disease. Right? In this one here, you're seeing a crypt abscess, which is a classical finding in ulcerative colitis. Right? This is a crypt. We're looking at a finger-like projection from a bird's eye view. Right? So in that crypt, we have an abscess. That occurs in ulcerative colitis. Right? Same thing here. If you look at it so now we're looking at it from a transverse view. We were looking at this in here from a top. So in this image, this thing here is being looked at from above, right? You see this guy, okay? So now we're looking at it from the side. So all these crypts, which are really there with, full of goblet cells, and their main function is to increase absorptive space, now they're full of abscesses, right? So you see crypt abscesses. And you see they have a side view as well as bird's eye view. You can get either one as a histologic image. The key thing you're looking for in these histologic images is that there's something in there, right? And there shouldn't be. There really doesn't need to be. Right, so here you can see the crazy distribution of the two, right? Ulcerative colitis, just your distal colon. How do you treat it? You can get rid of it. Just cut it all out. Cut this entire shit out, including the rectum. And of course that sucks for them, but they'll live and their life actually becomes better than having the colitis. For Crohn's, you can't do that, right? It's in different parts of the small intestine. It's in this area of the ileocecal area, and then it's in different parts of the large intestine. So it's pretty much everywhere. It can even be in the mouth, esophagus, and it sucks, right? So Crohn's sucks. Creeping fat, the creeping fat they were talking about, that causes the cobblestoning. It looks like this, okay? So normal is nice on the far left. In the middle, what you're seeing is that the fat is now wrapping around, okay? It's wrapping around, and inside, you're noticing this cobblestoning rather than it being nice and smooth, right? Cobblestoning is occurring. So that cobblestoning is mainly like, if you Google an image of cobblestones, let me see what I can find right here. Okay, so basically it looks like this. Right, so that's what they're referring to as cobblestone. You've all seen roads like this that you walk on it, right? Cobblestone appearance, this thing, it's not what your colon is supposed to look like. And what happens is, since this isn't such a nice thing to have in there, it can crack. You see how you have a fissure there now? It can crack, and now this vaguely stiff, smaller lumen colon is creating this fissure that can actually cause inflammation to pass through it and cause fistulas to form when enough inflammation occurs going through that ripped area, okay? Whereas in ulcerative colitis, it's ulcerations. All you see is ulcerations throughout it. All right? And those ulcerations all end up looking like polyps, but they're not really polyps. So it's called a pseudopolyp. All right, so that's what they're showing you. You see real images from the scopes, right, when they're doing the colonoscopy. This is how it really looks like when you look inside with the colonoscopy in a patient. So these are nice images. In the far right here, we're seeing toxic megacolon, right, due to ulcerative colitis. So your colon is really, really big now. Remember that the small intestine is in the center. So it's not that we're visualizing the small intestine, we're visualizing the ascending, transverse, and descending colon. All right. So these were nice things that were revised in step 1 due to high yield topics. The two other high yield topics are the erythema nodosa and pyoderma that we already talked about, and then this thing, urinary calculi. So impaired bile acid absorption in the terminal ileum in people with Crohn's disease leads to bile acid in feces with subsequent fat malabsorption. You lose your bile in your feces. Lipids then end up binding calcium ions. Okay, all the lipids are now binding calcium ions. But oxalate is actually supposed to be the guy that binds calcium ions. So all this oxalate didn't get to bind the calcium ions now because your lipids did. All the lipids you didn't absorb. Now the free oxalate is absorbed into your body, and it's going to form urinary calculi by binding calcium in your renal system. So you get calcium oxalate stones. Right? They also lose fat-soluble vitamins and get gallstones. Right? So all kinds of issues that occur. And this is often tested. This topic shows up in questions talking about all of this stuff, and then you're supposed to understand from reading all of that stuff that the patient has Crohn's disease. Right? So toxic megacolon, C. diffuse infection is usually a big deal in there. So that table here is showing you all of that. The book talks about, let's go back up to the top. So inflammatory bowel disease includes Crohn's disease and ulcerative colitis, most common in whites and Ashkenazi Jews. So, okay, they do mention it here. So I guess it is a real statistic, right? Because my patients were all white. Every patient I had with either Crohn's or ulcerative colitis, they were all white people. With onset, most frequently occurring in the teens to early 30s or in the 50s. So it has a dual distribution in young or after middle age, but not in middle age. The table summarizes stuff we already looked at. In patients with a history of Crohn's disease and acute abdominal pain, suspect small bowel obstruction, which is caused by fistula formation. Ulcerative colitis does not have fistula. So again, here, those fistulas that were causing connections in between parts of your own bowel loops, right, between bowel loops, those connections between bowel loops are not supposed to be there, and your bowels can get messed up, and then you can have a obstruction of your small intestine, right? Because if we come back to here, so this is unwrapped, right? This is showing you an unwrapped version, but imagine that this small intestine was going like this, right? Because it's all over the place. And imagine that maybe here to here, these two parts of the large intestine are connecting. That connection can actually mess up that portion of the small intestine that's going through there, causing a small bowel obstruction, right? So that's what they're talking about. The fistulas in Crohn's disease can cause small bowel obstructions. A lot of Crohn's disease questions, because there's not too much to talk about in ulcerative colitis. So you have all these extraintestinal manifestations that are shared by both, but the exam features here with fistulas and perianal fissures and in connection with the extraintestinal manifestations really give away that the question is going to be about Crohn, right? So you look for these things. Once you realize that your question is about IBD, you look for these things. Step 1 had other things that were helping you figure it out, right? For example, the microscopic morphology involved Th1 mediated response in Crohn disease. So you could remember Crohn as CR1, right? C-R-O-N-E, Crohn, Th1. Ulcerative colitis is 2 words, so it was Th2. So I never forgot that after I made up that little thing I just said to you guys. I would always remember that. And the type of granuloma, right? So the Crohn disease has non-caseating granulomas, whereas ulcerative colitis is a colitis. There's no granulomas there. It's just a colitis. It's inflammation. Inflammation can cause abscesses, it can cause ulcers, it can cause bleeding, but not a granuloma, right? So as soon as you saw granulomas or Th1 mediated immune response, you knew it was Crohn's disease. So that was a step 1 thing back in the day. All right. After that, the next topic is hernias, which are of course a huge topic, and then it goes into biliary disease. So let's look at the hernias, because here they don't talk about it in too much detail. But in step 1, this was extremely annoying. So inguinal hernias are protrusions of abdominal contents, usually the small intestine, into the inguinal region through a weakness or defect in the abdominal wall, classified as either direct or indirect. There are also femoral hernias, which occur in females, so female femoral. Okay, so let's take a look at it. Indirect is a herniation of abdominal contents through both the external and internal rings, lateral to the inferior epigastric vessels. Okay. Etiology is due to congenital patent processus vaginalis being weak. Okay. And the prevalence is, this is the most common one. This actually is the one that will occur the most, and it usually occurs in men. Okay. Then you have your direct one. This is a herniation through the floor of the Hasselbalch triangle, medial to the epigastric vessel. It's due to a mechanical breakdown in the transversalis fascia resulting from age. All right, this is going to be grown-up adult men. And then women, femoral hernias, herniation below the inguinal ligament, through femoral canal, below and lateral to the pubic tubercle. Increased intra-abdominal pressure or weakened pelvic floor muscles can both lead to femoral hernias, and this is more common in women than in men. Right, so here in the image here, you're seeing it. You have your femoral hernia right here, right, which is, of course, also medial to your femoral artery under the inguinal ligament. Right? The step 1 was all about knowing the anatomical location of these things, right? So notice the key difference here. The femoral hernia is under the inguinal ligament, whereas the direct and indirect inguinal hernias are actually occurring in here, in this opening. You see? Right? It's just that the path they took is different in both of them. Right? But these are really good pictures here to show you what's happening. So here it kind of slipped under. Why? Because of really bad pressure above, increase of intra-abdominal pressure, or weakened pelvic floor muscles, which can happen maybe after multiple deliveries and stuff like that. So that's why it's in women. The direct inguinal hernia is to what do you call it? Medial to the epigastric vessels, right? Medial to the epigastric vessels. So of course, this is the medial side, this is the lateral side, because we're looking at the right side of the patient. Right? This is the right leg of the patient. So always remember the van mnemonic: vein, artery, and nerve, from medial to lateral. Or in step 1, there was also the naval mnemonic, which NAV went from from out towards your navel. You have NAV. That's what it was. And I think there's alpha lymphatics as well. But either way, this is happening medial, right? This is a direct hernia that's occurring medial to the epigastric vessels. In the indirect one, the herniation itself actually occurs below and lateral to the pubic tubercle. Oh, where am I? Sorry, not the femoral one. This one. Herniation occurs lateral to the inferior epigastric, right? And they're showing it to you right here. This is the point of the herniation. Right, so the point of herniation here was actually right there. That's why it's called direct. It came out of the actual hole itself, so it's direct, right? The indirect one didn't come out of the hole itself. It actually took a weird path all the way up here, right? And that's right there in the deep inguinal ring, and went through the ring and came out in that hole. Right? That's what you're seeing here. It went through that ring and came out. Okay, so these guys are mainly just tested in terms of an anatomic position, you figuring out that it's happened, and treatment. Again, like here they show you more pictures of the same stuff, but treatment, because of the risk of incarceration and strangulation, surgical correction is all you need to think of. Right? Of course, this is clearly being strangulated, and so is this one, and that is not good for you, so you need to surgically correct it. That's all there is to it. So thankfully, at least in CK, this is easier than it was in step 1. In step 1, this was a very intense topic, right? And very annoying topic too. Actually, I don't even remember where. This isn't even in GIT in step 1. I believe in step 1, this was discussed in musculoskeletal. So yeah, you see that in some part of musculoskeletal. They don't even keep it in GIT anymore. Right? But it is in GIT here, and it's important to keep in mind you know how to treat it. Right? Because this sucks. And of course, the testes the testes get involved as well. In this case scenario right here, in B, with the indirect, because it goes into, indirect goes into where the peritoneal sac, where it comes into where your testes are. So this actually ends up overheating the testes too. Right? Because of course this entire herniation is really hot stuff. Right? Whereas here the herniation is over there, so it doesn't come into where the testes are. It doesn't go into the ring. Right? So these are basic things as far as step CK is concerned. MDs Don't Lie was a really good mnemonic back to step 1 to remember the positioning and the anatomy. But you don't really get any really crazy intense questions about this on CK, because there really isn't much to do. Management is very easy. You just do surgery. So they can't make you pick between like 10 different answer choices for it. All right. After that, there's a bunch of practice questions to look at, so you definitely want to make sure you spend some time going through all of that. I wanted to come back and look at this one real quick up here. So this is a 26-year-old man, comes to the ED with 4 weeks of lower abdominal pain and cramps accompanied by rectal urgency, bloody diarrhea, nausea, and decreased appetite. This is a pretty young guy with bloody diarrhea for 4 weeks. Okay, this is pretty weird. His symptoms have become severe over the last 2 days. Medical history is fine. He hasn't traveled or used antibiotics. His temperature is high. He has fever. Blood pressure is low. Abdominal exam reveals distension. What is... Oh, I would dig... this is supposed to be FF. Diffuse tenderness to palpation. And low bowel sounds. No rebound tenderness. Rectal exam shows tenderness and mucus mixed with blood in the vault. Okay. Lab results show a low hemoglobin, high leukocytes, platelets are 459K, slightly high ESR, so there is inflammation. IV fluids are started and blood pressure improves, right? Because remember, the first thing is always to stabilize the patient, right? So they're doing it in the question for you. So they've done the stabilization portion. Then they ask you what's the next best step. 35% of people chose the correct answer, abdominal x-ray. But for some reason, 30% of people chose to do a colonoscopy with biopsies. So you now wonder, what are they thinking of here? Or is there something that they didn't realize? So this patient with weeks of lower abdominal pain, bloody diarrhea, fecal urgency likely has undiagnosed IBD. He's a young man with all these extremely weird symptoms because this is probably Crohn's or ulcerative colitis. His presentation suggests toxic megacolon. If due to severe colitis, this may be the first presentation of IBD and is potentially lethal. Radiologic evidence of colonic distension with systemic manifestation is key to the diagnosis, because ulcerative colitis does have extraintestinal manifestations as well. Thus, initial test of choice is an abdominal X-ray, which is non-invasive and quick, to confirm the diagnosis and exclude perforation. Conservative management with bowel rest, nasogastric suction, and corticosteroids with broad antibiotics or antibiotics for C. difficile are going to be necessary, and then he'll be okay. Barium enema, right, with the colonoscopy with biopsies or barium enema. Barium enema is contraindicated in cases of suspected IBD, and endoscopic evaluation would be great for confirming IBD had he presented earlier. But since he's presenting right now, so you understand that people chose colonoscopy with biopsy because it is what you have to do to diagnose ulcerative colitis. Well, yes, but since now, at this exact moment, he has toxic megacolon, doing a colonoscopy is not really going to help, because you'd be looking at the toxic megacolon, which really doesn't help at that point. You're going to make things worse for this patient. So you just do an abdominal X-ray, you visualize a toxic megacolon, you know what's happening, you tell the patient he most likely has ulcerative colitis, you treat them, make things better, wait for the toxic megacolon to go away, then you can do the biopsy to get a 100% confirmed diagnosis on the ulcerative colitis. And then that's it. Right? So he's a young guy, and this is how it is. Although most patients I had were not young. I mean, they were long-term patients of that doctor that I was working under. So, they were just living through life and dealing with their Crohn's ulcerative colitis as they have to, and they were doing fine. They were doing fine. Thank God to modern medicine. And then let me see. So that's a pretty. This is a really good question, but it's pretty straightforward and easy regarding a small bowel herniation. It was just really weird how only 50% of people chose the correct answer, but then 10% each chose between these two answer choices, and it was just, to me, it didn't make sense why they were choosing those answer choices. This one was really just here to show you how to deal with anal fissures, right? So that wasn't so bad. This one here was an anal crypt gland issue with just an infection. 50% chose it right. 25% chose thrombosis of an external hemorrhoid, but this answer choice of an external hemorrhoid wasn't that logical to pick in this question either. So you'll take a look at that. Study these questions really well. They're all questions that are directly related to the topics we've been talking about, and they have a lot of questions where people just chose the wrong answer choice way too frequently. Like this one here, 30% got it right, 30% chose this other thing or that other thing. So, people were everywhere. If only 30% of the people got it right, you definitely want to spend some time on it. And then in the next video, we'll go into biliary disease. All right, so thanks a lot for joining, guys, and then enjoy the rest of your night.